I'd like to welcome everybody to the June 26th IMAG-MSM Working Group on Multiscale Modeling in Viral Pandemics and GLIMPRINT mini seminar series. We're very pleased that Julia Arciero is coming back. She gave a talk earlier several years ago on some of her other immune-related modeling. As always, I need to remind people that this meeting is live streamed and recorded and made available on YouTube afterwards. Tom Helikar, myself, Jim Sluka, and Lorenzo are always available to take your comments and suggestions. Don't be shy about telling us what we can do better. We have a variety of communication channels. We'd appreciate it if you could help us get the word out about these seminars and about the archive of recorded talks. Please feel free to suggest better ways of communicating to make sure that people are aware of this series and its materials. We have been talking about changing the branding. There is a virtual human development group in Canada that has a seminar series that covers somewhat similar, mainly developmental multiscale modeling, but also experimental techniques. And they are interested in offering seminars jointly with us. I think that's a great idea. We've been talking about possible names and ways of presenting that. It happens that their seminars are regularly at the same time as ours on Thursday morning now. So it is something that we would like to think about a little bit. So if you have suggestions for what we might want to do about that, please let us know. If you have a publication to share, we can put that up on the IMAG page. We always want to help build the community. And so anything that you think would be appropriate, please send that to Jim Sluka, and we'll do our best to get that posted and publicized for you. We have also on the GLIMPRINT page the ability to post your papers, your seminar announcements, conference announcements, job postings, funding opportunities, and so on. If you'd like to do that, please let us know. They should be able to do it directly. If it doesn't work, come back to Jim, and we'll do our best to make sure that it happens. Again, our goal here is to build community. There are a couple of things coming up that I want to let the community know about. There's going to be the Combine 2025 workshop. That's going to be October 20th to 23rd in Madison for our U.S. participants. That should be convenient. It's a great meeting on model sharing and standardization. So if you're interested, I would encourage people to look into that. Many of the people in this community are involved in that. And so it's a great way to build connections and also to present your ideas. There's going to be a networks modeling course online with a hackathon sponsored by Herbert Sauro using his antimony modeling techniques. If you'd like to participate in that, the registration deadline is July 20th. That's a great course. I strongly encourage people, especially for students, postdocs, or people who haven't done network modeling before, definitely worth participating there. We have a workshop coming up on July 29th, August 1st, in person in Georgia on forecasting viral spread with limited data. The registration deadline is closed. However, if you are interested, especially for students, you should reach out invisibleworkshop@gsu.edu, and there might be a possibility of late registration. We still have openings for our 2025 CompuCell virtual tissue modeling workshop and hackathon. That's going to be spread out over 2 weeks this year. It's going to consist of a basic CompuCell course in week 1, an advanced CompuCell course in week 2, a hackathon course at the end of week 2. There's also going to be a Python introductory tutorial as well. The registration deadline is officially June 30th, but that's a soft deadline. If people would like to participate, we'll do our best to accommodate you. Since it's a virtual course, we have some flexibility in terms of accommodating people. Coming up pretty soon, there's going to be the SMB meeting in Edmonton. GLIMPRINT is sponsoring 3 mini symposia. Many people in the community are speaking in those mini symposia. There are also going to be 3 mini symposia for OpenVT on model sharing. And on the Sunday before the main meeting, there's going to be a day teaching multi-scale modeling methodologies and discussing model sharing. And I'm also going to be teaching a 1.5-hour CompuCell mini introduction on Wednesday during that week. If you're interested or want to sign up, please follow these links here. There's also this coming up ISMB, July 20th to 24th meeting, which the NIH has been sponsoring, and I'd encourage people who are interested to follow up on that. That may be getting a little bit late, but I don't know what the opportunities for participation are at this point. Coming up, July 10th, we are going to have Jacob Barak talking about the COVID lessons learned, going back to the origins of this seminar series and working group. And then we're going to have a roundtable discussion on July 24th. Lorenzo Veschini is going to be presenting on August 7th. We're going to take August 21st off. Too many people are on holiday. And then we'll start back on September 4th and September 18th with some more talks. If you have suggestions for speakers, please let us know. They could be experimentalists, modelers, people in communication, anybody that you have in your group, undergraduates even, postdocs, graduate students, anyone you would like to have speak. If you've spoken before and you have new material to present or it's a different topic to present, don't be shy about suggesting yourself again. We're pretty good about getting people that you'd like to hear to speak, so let us know who you would like to speak, and we'll do our best to get them on the roster. Lorenzo is very effective at that. This schedule looks pretty full, but we always need more speakers, and our goal is to bring in people that you want to hear. We are going to have a steering committee meeting tomorrow at 11 a.m. Eastern Daylight Time. If you would like to participate and you're not invited, let us know. If you think that you should be there, we are happy to invite you. And we're going to be talking more about this coordination with a virtual human development project seminars as one of our main topics. Okay, today we have C Arciero coming to talk to us about modeling novel immunoregulatory treatments for transplant patients. Great topic for us. I don't want to take more of your time, and I will turn the screen share over to you.
So this is work that I started, maybe 10 years ago with Giorgio Raimondi. He's an immunologist at Johns Hopkins. We actually happened to know each other in Pittsburgh, although we didn't formally work together until we had departed into different institutions. And he had approached me because he felt that transplant immunology was really missing a lot of the benefits that mathematical modeling can provide. And at the time, really, there were no math models of the time trajectory of a rejection. So the first thing he wanted to understand was how a transplant gets rejected and if we could use mathematical model to explain that. And then today I'll kind of describe how we've kind of developed from there, the different steps we've taken in modeling, and now the types of treatments we're hoping to look for going forward. So as I'm sure this audience knows, the goal of transplantation is to restore the functionality of an organ. It can certainly improve the patient's quality of life dramatically. And there's multiple different types. We tend to focus on heart transplant because we had data from mouse heart transplants, but certainly skin, kidney, lung, liver. There's lots of different transplants, and different models would, our model could be adapted to different organs, although things such as skin or that have contact with the kind of extracellular space and not just within body would have to have different adaptations made, I think, to the model. So the one that we'll focus on has really been heart transplant. And so what was the original motivating question of this project, and how are we trying to address it? So ultimately, if you don't have outside intervention like immunosuppression, the immune system would recognize a transplanted organ, or what I'll also call a graft, as foreign. And so your body will obviously attack this. And no one wants to actually make it to the top of a transplant list and then not have it be successful. And so the current solution for this is that there's long-term administration of immunosuppressive drugs for these transplant patients, which of course is life-saving. And but the problem with that is that there are a lot of associated complications. So someone who's on immunosuppression certainly has a different quality of life. They are more likely to succumb to different infections. They have increased risk of other types of diseases, heart disease, cancer, diabetes, and ultimately their lifespan or the long-term acceptance of that graft or tolerance to the graft is not the same as if they had their own personal organs still intact. And so one thing we've wanted to study, and that my collaborator Giorgio was very interested in, was could we find different ways to achieve tolerance of the graft without relying on this long-term administration of immunosuppression? So certainly we still have to suppress the immune system, but could we find other mechanistic approaches through therapies that could still allow for transplant acceptance, but not necessarily lead to some of these associated complications? So that is overall the big picture of what we're trying to accomplish. And so, as I mentioned, from the beginning, we first wanted to say, can we make a mathematical model that just talks about rejection of a transplant? And so I'll show some of those data sets that we had and the original model. And then the next step was to start studying this idea of adoptive transfer of regulatory T cells. So on some of my slides, you'll see AT for adoptive transfer. And then, of course, I've already mentioned the idea of immunosuppression, which you'll sometimes see as IS on my slides. So this is kind of a current strategy, and then adoptive transfer is something newer. And so actually, before we created a model that had immunosuppression, we actually took our model of transplant rejection and added in adoptive transfer. We looked at changing dose levels. We looked at changing timing strategies. We looked at where we were putting in this adoptive transfer, so location of them. And that was kind of our next paper, because we were really interested to see, can the adoptive transfer of regulatory T cells lead to tolerance of the graft? And so what is adoptive transfer? So the idea is that regulatory T cells are so your T cells, you have kind of more effector and helper cells, and you have regulatory. So they're the ones that inhibit, try to maintain the balance so you don't get overinflamed. So they're regulating things. And so in this case, they would be reducing the amount of CD4s and CD8s, the amount of effector T cells that would be attacking the graft. You would have Tregs would be reducing that. So the idea is, can we extract activated T cells, expand them outside of the body, and then infuse them back into the patient so that you're providing them a bunch more activated Tregs that could then orchestrate this to inhibit the destruction of the graft, to prevent that. And so that's what we studied, and I'll show you some of those results that we had. And ultimately what we found was that it would delay the timescale of rejection, but it did not actually lead to graft tolerance, at least not at the dose levels that are reasonable. And we've seen other studies as well. I could show you some, but plenty of studies have shown that adoptive transfer in isolation is really not sufficient to prevent the rejection of graft. So then we decided the next step was to take our model and add in immunosuppression, since that's what the current regimen is for a transplant patient. But then, and so, the goal of immunosuppression is really just to dampen the entire immune response to prevent rejection. One of very typical ones that's used is called cyclosporin A, which is a type of calcineurin inhibitor. So you'll see me use the letters C and I as an abbreviation for calcineurin inhibitor. And that's one that we're going to be looking at in our models. That one tends to have less side effects, more tolerable for a patient. And so our next step again in the model was to say, okay, let's put in immunosuppression, look at the mechanisms by which immunosuppression acts, show how we can get tolerance to the graft with kind of a regular cocktail of immunosuppressive drugs. And then our next goal is to say, okay, now can we kind of balance the two? Could we maybe dampen immunosuppression and add an adoptive transfer and see how could combination therapies work? And so that's kind of it's kind of a work in progress still. In fact, I tend to have this project for my REU students. So it tends to a lot of times be summer projects, and it doesn't always get as much attention throughout the entire academic year. But I've had a lot of students work on this, so I'll kind of show you what they've been able to accomplish in the recent past. So ultimately, we're taking an iterative approach, just as one would do in any kind of modeling. And I'll show you step by step kind of the mathematical model regarding compartments of a graft and a representative lymph node. And we do have some experimental data, although we're trying to get more, especially in the mechanism of immunosuppression aspect. So we want to look at new interventions that could still lead to transplant rejection. So as I've kind of already outlined, the main objective is that I'm going to show you how we simulate current mechanisms of immunosuppression. We'll add in adoptive transfer to look at that. Look at if there are key pathways that one could target that could maximize the benefit of adoptive transfer. And so we'll talk about some genetic modification that could be potentially done on the adoptively transferred Tregs. So that'll be part of, towards the end, what I'll show you. And then ultimately, and we haven't fully accomplished this yet, but could we vary these strategies in combination to optimize graft acceptance? And again, please feel free to ask questions, unmute yourself if you have questions as I go along. I do not mind being interrupted. But so let's talk about, so I didn't want to, it's actually an ODE model of a lot of equations, so I didn't want to show you just all the equations. So I thought a picture would be better. So we have the graft, so that's the transplant, and then we have a representative lymph node or lymphoid tissue. And for initial the populations, so we're basically tracking populations in the graft and the lymph node, namely what we're characterizing as immature antigen presenting cells or APCs, mature APCs, inflammatory APCs, and then 3 types of T cells. So the regs, Tregs, the CD8s, which are effector T cells, CD4s are the helper T cells. We're tracking the number of graft cells. And then we have, at this point in time, we haven't separated out specific cytokines. We just have a population of pro-inflammatory and then a population of anti-inflammatory cytokines. So those all will reside in the graft, and in the model, I will show 1 or 2 sample equations would have a superscript G to represent graft, as opposed to those with superscript LN for lymph node, where here we're tracking mature APCs and then also the T cells, same T cell populations, only the ones that are in the lymph node, as well as naive versions of these that become activated. And we assume there's this constant or background supply of these. And then immunosuppression will be kind of this new variable that we add in to look at its impact on the different model components. So initial conditions, meaning what's the initial condition of the graft directly after it's transplanted? So you're going to have the number of cells is certainly positive. So it's a very high number of cells. You'll see the initial condition. Now, after having a surgery, you're going to basically express a lot of pro-inflammatory cytokines. So and I didn't provide the actual numbers here. I could have, but I just said you have a positive number of pro-inflammatory cytokines and immature antigen presenting cells. So these are all positive in the graft. The remaining populations are 0. And then in the lymph node, again, those naive populations are positive and constant. They remain as a background level. And then if we're modeling immunosuppression, then we would start with some initial level of immunosuppression. Okay, so then once the graft is actually transplanted, post-operative day 0, you've got the graft inside. The APCs, this is just more or less a schematic. So here's the immature APCs becoming mature APCs in the graft, and they certainly lead to the production of cytokines. But ultimately, I'm trying to show you that there is going to be the translocation or presentation of the APCs to the lymph node. And then in the lymph node, I'm looking at, these are the naive on the left, different helper, effector, and regulatory T cells that in the presence of the mature APCs will cause activation of the T cells into what we're calling the activated state of helpers, effectors, and regs, where the regulatory T cells have kind of this blunted arrow. They're thereby inhibiting the activation process of these T cells, and the helpers and effectors actually promoting, so the forward arrows. And so all of these interactions are basically put forth in a model, but I'm just showing it to you kind of pictorially. And then the next step is that upon activation, these activated T cells are going to translocate to the graft. Not all of them find the graft. So we have parameters in the model that account for the fact that only some amount actually make it to the graft. But then you have the new population. That's what I meant by the superscript dictating the fact that these are the ones that actually are activated in the graft. And then the destruction term, and I'm not showing like the cytokines and everything, otherwise there'd be too many arrows going on. So this is kind of the just kind of key mechanisms. So if we think about the graft cells being destroyed here, well, they're being destroyed by effector T cells and inflammatory T cells, but the regs are trying to inhibit this, just as the regs also inhibit the differentiation of immature APCs into mature APCs or inflammatory APCs. And so that's why adoptive transfer is thought to be so beneficial, because if you boost the number of Tregs, then you're basically improving the ability, because you're providing more of these cells, to block key pathways that would ideally prevent destruction of the graft. Of course, T helpers actually are harmful here in an indirect pathway, right? So they help promote the differentiation of immatures into inflammatories, which then destroy the graft. So in a nutshell, that's more or less the components. We're not at this moment taking into account B cells or memory cells. We're really just kind of looking at this basic model of how we could look at rejection of the graft. And so here's kind of the big summary picture. And I'll show you again when we add in immunosuppression, but these are all those steps that I just went through, looking at the interactions. And so there's, I think, like 16 ODEs, although these guys are pretty much at steady state because they're always constant. So it's really 13 ODEs. And they are parameterized. Okay, I'll talk about that in a second. Here's a sample of one first, and then I'll talk about how they're parameterized. But like I said, I didn't think it was necessary to show you the entire system. But here's, for example, without any treatment going on, a regulatory T cell in the graft. So we have some entrance. So basically the lymph node regulatory T cells are going to enter, and then a probability of them are going to find, proportion of them are going to find the graft. So you have how many are actually translocating into the graft, and then some natural decay. And then this is the ability to proliferate, kind of a saturated ability in the presence of effectors and helpers. And so I'll use this as our sample of equation in future slides to show how we add in adoptive transfer or how we add in, say, immunosuppression. As I was mentioning, parameter estimation is always tricky in big models like these. And so my collaborator, Giorgio Raimondi, had measurements of T cells in the heart on postoperative day 7. So he was measuring CD8, CD4s, here's their ratio, and also Tregs, and the percent of these of CD4s. And so he had some of this data in addition to kind of another large set of data. So this is taken from different papers that ultimately, you don't have to read through all of this. The main story is, okay, we understand APCs will peak in their population levels at a certain value and at a certain time. So between days, say 1 and 3. And then we also had data on like the peak number of cells. We also had, so this is an important paper and it will come up again, so I should explain this. I didn't show the graph of it, but Tanaka et al. Basically measured, they do a beating score of the heart. So, and it's basically looking at, it's a luminescence study to measure, I guess the mass, you can think of the mass of the heart transplant and the beating score. And so what was shown was, so I should say this. So they have the luminescence and they're tracking luminescence of these cells over time. And what we saw was that the cessation of the heartbeat, or once, I think it was like on day 11 or 12, the heart was no longer beating and the luminescence score had dropped to 25% of its original level. And so this was kind of the marker we used, since we don't, to kind of say, okay, well, if we think about luminescence relating over to the size of our graft, we are setting our kind of rejection line at 25% of the original graft population. And we needed that to occur at day, I think it was between 11 and 12. So we had the timeline of graft destruction from that study. We had those T cell ratios from Giorgio and the timing of their populations at which they peaked, also from my collaborator. And then there were other studies where they remove helper T cells, or in the absence of effector cells, they talk about, well, in this case, no rejection would occur or would be delayed slightly. And then if you have all T cells absent, we also have APC measures from other papers. So using this data set, and then also I should mention, numerous parameters are set from previous models of basic T cell interactions. So we have certain values that were just based on other models that had used typical data of, decay rates of T cells and things like that. So those were kind of set based on literature. Then we did a fit, and Guang Lin, who is a statistician or specialist in uncertainty quantification at Purdue, is one of my collaborators, and he actually worked on the sensitivity analysis and calibration of the model with me, as well as some of our students, where, really our quantities of interest that we were paying close attention to was the mass of the graft, the number of effector T cells that infiltrated the graft, and then the mature APCs and inflammatory APCs in the graft. And then he did both a local and global sensitivity analysis to understand kind of what were the key parameters that we were looking at. And then he used this simulated stochastic approximation annealing procedure to calibrate those sensitive parameters with the data that I showed you. I'm not going to focus too much on this since he was kind of the one who did that and that wasn't my part of the picture. But all of this to say, these were the processes we underwent to find the remaining parameters for our model. And so this would show, as an example from our from our initial paper back in 2016, the timeline of rejection. And I wanted to show this plot just because I wanted to introduce you to the idea of the rejection threshold. So what's being plotted here is graft cells, the number of cells. So at time 0, you have a large number of cells, versus time. And that Tanaka paper helped us set the rejection threshold at this line here. So it's 25% of the initial population of the graft. And then we've chosen an arbitrary, what we call a therapeutic threshold later to understand the idea of how successful a treatment is. And so basically the idea is if we felt, and it's a bit arbitrary, but for the sake of this model, if a graft were to lose more than 10%, so basically this is a 90% line, if its graft size decreased below that, then we would not consider that a successful treatment. So basically, to be a successful immunosuppression regimen, it has to be above this 90% line. So that's what you'll see on upcoming slides as the therapeutic threshold and the rejection threshold. And so I just put in a dotted line here at the intersection. So at the point where the graft lost this number of cells would correspond to when a heart would stop beating based on that experimental paper. And so that was around day 11-ish. So that was to say that was one of the things that helped us optimize the parameters of the model. And so we had ourselves a basic model of transplant rejection. And so the next step was to add in the adoptive transfer that I described at the beginning of the talk. And so here's that same equation. And the only difference for now, and I'll talk about how we're going to separate out the Tregs later, but the only difference in this regulatory T cells in the graft equation is the idea that now we have a dosing function. So this D of T function, we looked at different ideas, one being a single dose of Tregs, and the other would be multiple doses, with the idea that the multiple doses in sum would add up to the number of cells that would be transferred if you had a single dose. So if we wanted to compare efficacy of differences, we didn't want to say, oh, we're going to put multiple doses, but all have the same peak as a single dose, because that's not really a fair comparison. So we wanted these to be, if you were to look at the area under the curve, how many total cells are actually being injected or infused into the graft. So these next few slides show you from a paper in 2022. This was, again, one of my RU students who worked a lot on this. She's first author on that paper, Maya Lapp. So she worked a lot on this adoptive transfer idea. And so as I was mentioning, so this is not the main part of this, but I wanted to show you what we found with adoptive transfer. And what we found was that if you deliver to activated T cell Tregs to the lymph node versus the graft, again, here's that rejection threshold line, and this is no treatment, so you're around day 11. You can delay the day of rejection, and putting them into the graft was the better place, so better than putting them into the lymph node. We looked at different dosing rates, like and so the amount of Tregs are these numbers along each of the colored curves, and the timing at which you implemented them. And then this is saying time until graft rejection. So like, again, 11 days is if you don't have any treatment. And so a low dose of adoptive transfer really didn't do that much better. I mean, maybe 20 days or something. But one thing to notice is that you have kind of this non-monotonicity. So not putting it at day 0 of the post-operative day, but waiting 2 days often tended to be better. Although for higher doses, it didn't matter as much. So basic idea was to say, if we use kind of a reasonable amount of cells that could be adoptively transferred, this is actually still kind of high. It was better to delay a couple of days than to do it right at the beginning. And then clearly waiting too long will have no helpful or beneficial effect. And then we also looked at the number of doses. So remember I said we could increase the number of doses and decide when we were going to put those or inject them, if it was on day 0, 1, 2, or 3, for example. And this is, again, the time until graft rejection. So in all of these cases with adoptive transfer, we're still rejecting, but we saw that there's always kind of a peak to each of these curves. And actually, if you had 14 doses, so there's a peak somewhere around here on day 0, that led to the longest delay in rejection, then than you had basically for any of the other cases we tested. So all of this to say, one can use, what's a good benefit here of mathematical modeling? Well, to do all of these experiments would be very, very difficult and costly, but here we're able to try to predict, okay, what would be some optimal strategies, and we can test a lot of different things in a quick amount of time. So that's kind of all of the older things that we've done. And so what we're most interested in now is, again, to put in the immunosuppression into the model and then do combinatorial therapies. And so here, this is showing that original schematic of the mechanism or the interactions of the different cells and things that we're going to target with immunosuppression. So for example, immunosuppression certainly targets the activation of T cells. It targets the destruction by CD8s, and it targets the differentiation that T helper or the helper T cells facilitate. But then we have to also pay attention that it's going to disrupt Treg function. So ultimately, immunosuppression is also going to disrupt the activity of adoptive transfer. And so that complicates matters significantly. And then what I learned was that patients are given kind of what I'm calling a cocktail of medications upon receiving a transplant, because they need to make sure, especially early on, that that transplant does not get rejected. So there's 3 that are very typical or common. So I mentioned CNI, that calcineurin inhibitor. And then there's also something called MMF and steroids. Now, they don't want patients on steroids for long periods of time. Eventually, this cocktail does not stay as it is at the beginning of a transplant, and CNI is kind of relied upon, to my understanding. But to begin with, to get this thing totally accepted, we have these things. And so here are the assumptions based on my understanding from literature and from my collaborator of how these different drugs act. So CNI is going to inhibit activation of those T cells. It's going to inhibit destruction of the graft by the CD8s. It's also going to inhibit the contribution of CD4s, those are the helpers, in activating both mature and inflammatory APCs. So the differentiation of APCs from immature to both mature and inflammatory. And then it also inhibits the regulatory effects of the Tregs when the Tregs are inhibiting APCs and inhibiting graft destruction. So in each of the model equations, the Tregs are found in the denominator. They have this inhibitory impact, and CNI is known to inhibit this part of the Treg inhibitory effect. And so I point this out in particular because that's one thing that we're going to think about, or that we do think about and show you some results about. Namely, what if we are able to genetically modify the adoptively transferred Tregs so that they're not affected by CNI in this way, so that those effects aren't being inhibited? And so I'll show you that if you can change that in CNI, you actually get quite a bit different result. The MMF is known to inhibit proliferation of T cells, both in the lymph node and graft. And then the steroid is going to inhibit basically the differentiation process of the immatures into both mature and APC and inflammatory APCs. Okay. So all of those things had to be added into the model, and we had a data set specific to the first bullet point. It was Otsuka et al. And one of my other students, McKenna Kazanowski, who's actually now at IU Bloomington in the math department, working on her PhD. She, with the help of Georgia, we found a data set that looked at activation or the impact on the activation of T cells for different levels of CNI, basically. And so she was able to do a fit. And so I'm not showing that particular equation here, but so there is one set of parameters based on, so I'm not showing activation of T cells here, but that inhibits the activation terms. And then the remaining terms, we basically assume that the rate, so in this case, the proliferation rate, which would be affected by MMF, is multiplied by some sort of exponentially decaying function of immunosuppression. And so one of the main challenges and the thing that Giorgio is hoping to design are, the challenge is, how do we know the relative contributions of these different medications? It's a little bit hard to get at. So we don't have exactly those data sets. So I've been having my summer students this current summer, start varying some of these parameters to see kind of how sensitive it is to each of these different types of mechanisms. But anyway, so ultimately immunosuppression is going to inhibit some of these rates. And we look at two different regimens for now. One, a constant dose of immunosuppression, which of course is like not realistic physiologically, but it's kind of best case scenario. So if you just had this constant infusion of immunosuppression, how do you do? And then we were looking at a tapered immunosuppression where we pretty much have it on for about 2 weeks. So constant is here, where immunosuppression dose per time, it's always on. The orange line is saying, okay, 2 weeks on at a high level, taper it over 3 months or about 90 days, and then taper down to a different level. And so I have another student working this summer on some bifurcation or 2-parameter bifurcation analysis to see if we can change that lower dose, if we change the length of the taper, or if, lots of different things we can vary to see what's going to be most successful. So this is just an example of showing you an outcome. So again, we're looking at graft cells per time. You see these thresholds that I explained. And so without any treatment, it's rejecting around day 11. If you have a constant dose of immunosuppression, and this is a pretty high dose, and by immunosuppression, I mean the cocktail of immunosuppression, we see that the graft is surviving, which was what we were hoping for, because the whole idea is, could we model CNI, MMF, steroids, and show that the graft does not reject? Now, then we tried like that 3-month tapering approach, and we see that the graft stays high for a little while, but after things are being tapered, it doesn't do well. So, which we also would expect, because a patient is always on immunosuppression, they don't really taper their dose. Otherwise, that's obviously the graft is in great jeopardy. So, what we want to know is, could one potentially put a combination therapy in this region, or somehow put an adoptive transfer and gain success with a combination therapy while reducing the level of immunosuppression so the patient has potentially a better quality of life. I did want to show you the contributions of components, because the synergy between the three is actually pretty interesting. So here, again, it's the survival of the graft size, right, versus time. And if you put in CNI alone at a specific dose level, it would actually not survive. And if you put in steroids alone, you definitely would not survive, or MMF, at least based on the inhibitory effects that are currently being assumed. Like, we've got kind of our best assumptions, but we still would like to have the data from Giorgio if he's able to. I mean, he knows how to design it. He just needs to actually find the time and money to make these experiments happen. But if we had a little bit more data, we could probably pinpoint a little bit better how exactly these three relate. All in all, though, the point is, in combination, the cocktail leads to survival. So you absolutely, at least at these dose levels, you need the cocktail to survive. So I thought that was important to see, that we're trying to understand how, and we're going to ultimately be targeting CNI quite a bit to see how things could be more beneficial potentially with adoptive transfer added in. And so I mentioned this a little bit earlier. I said that we wanted to split the Tregs into 2 populations. So the ones that are living in your body already, so the endogenous ones, and that's the same equation I've been showing you all along. And then we want to track those that are adoptively transferred separately. So I have this subscript for reg, but comma AT for adoptive transfer. And so the only difference here is those obviously were not ever in the lymph nodes, so they're not entering, but instead you have just this infusion, so a dosing function, but there's still a decay and they still can proliferate. So it was actually, this is pretty recent. My students this summer, the past 4 weeks, put this into the model to keep them separated. And now, and I will always try to remember to show you whether or not I'm modeling the cocktail or CNI alone. And so here's, because you're very used to seeing graph versus time graphs, I wanted to show you, assuming a constant dose of immunosuppression, where in this case, immunosuppression means only the CNI, only the calcineurin inhibitor. Remember, as I showed you before, CNI alone, when I showed you those different mechanisms, didn't lead to survival. So this is saying CNI alone, but no adoptive transfer. So we don't get survival. And then we added in adoptive transfer. And the red was if you did not modify. So I was talking earlier about genetically modifying the Tregs that are adoptively transferred. So namely saying, if we infuse with adoptive transfer Tregs that are manipulated such that they will not be inhibited by CNI versus not. So red is saying no modification to those Tregs, and blue is saying yes modification. And at this high of a dose, first of all, we see that adoptive transfer actually is very helpful in leading CNI to success, because CNI alone was not successful, but in the presence of adoptive transfer is. And yet, whether it's modified or not a huge difference at this high dose. Now, if you reduce your dose, we actually see a major difference between modifying it or not. So again, no adoptive transfers here. No modification did not do well, so it still did not survive, but the genetically modified Tregs did. And so that was what Georgia was very interested to see. And so I have a summary, basically like a steady state, kind of a bifurcation diagram, right, of a steady state level versus immunosuppression dose. So again, it's a constant dose, and I know it's a little bumpy. They take a little while to run, so I only discretized so much here. I could make this smoother, but CNI only, constant dose, and so this is CNI without immunosuppression. This is the graft steady state. So where does it land after a long period of time? And we see the CNI, as we saw in the previous slides, it did not survive. It rejected in the absence of CNI only, in the absence of adoptive transfer. So that's the dashed line. And when you put in adoptive transfer, and these are genetically modified, we see that for the doses, basically above 20, like I showed you on the previous slide, you can actually get survival. But as the dose is reduced, the ability for adoptive transfer to help is only so much. And then eventually they are pretty much on top of each other. Then I tried a tapered dose. And again, I could make this smoother, where I'm now varying the final dose of the taper. So if you stay at 30, that pretty much you're at the constant level. And if you taper down to 25 after the 3 months versus 20, etc., we still see, and it's a pretty similar shaped curve actually, but adoptive transfer is still helping. But if your final dose gets below, I don't know, something between 15 and 17, or wherever this ends up curving down, you're not going to be successful. So that adoptive transfer in that region of taper can only do so much. Now this set of graphs is maybe a little bit disheartening. So well, it's not necessarily disheartening. It's more to say the cocktail is very strong. So this was to show almost, well, more or less the same thing. Graph of the steady state versus dose, or final dose. If we taper it, this is constant. And the dotted line and the full line are on top of each other, namely meaning the cocktail is so strong that adoptive transfer really doesn't help. But once you get below a certain dose, adoptive transfer can't really do much anyway. And so we do see that those genetically modified Tregs are helpful for CNI, but when you're within the cocktail, oh, and this should say cocktail. That's a mistake. Sorry. These are both cocktails. It's not quite, it's not as evident because the cocktail's so strong, you're having survival. Okay. And then this is showing now the timing of adoptive transfer, because we did all of those other preliminary studies back with my student Maya in like 2020 through 2022. And we were curious about the timing of the dose. So we remember we had seen like a slight non-monotonicity. And so here, again, this is CNI only with the genetically modified Tregs. This is the steady state value and the day of adoptive transfer. So clearly with CNI alone, it's constant because we're not having adoptive transfer. So this is where CNI would land. So you don't get survival with CNI alone. And this was a constant dose, I think, of 30, but like the highest dose that we really consider. And so adoptive transfer, by default, we tended to use day 2. This actually shows that in this case, day 0 is a little bit better. But ultimately, it's saying you need to put adoptive transfer early on. Otherwise, you start to lose its benefit. And that is also because that's when the Tregs are, well, if you think about the time frame of when the Tregs are peaking anyway, from also coming in from the lymph node, the ones that are endogenous, that's, you want to hit it while they're peaked before they decay. So waiting too long is not helpful. Now, unfortunately, this was a little bit disappointing, at least what we've seen so far, which is that with a tapered immunosuppression dose, now I will say, and this is why my student working on some 2-parameter bifurcation diagrams, because this is a single one. So we're only varying the day of adoptive transfer. The tapering is saying starting at 30 and tapering down to 12. Well, maybe if we varied what we taper to or the length of the taper, adoptive transfer could be more useful, but ultimately we don't get survival. Now this goes up a little bit, and I actually want to take this out longer because since the taper is 90 days, we should take this out for longer to see if we get any kind of better recovery here. And then this one is the dose of adoptive transfer. And this one is very important because ultimately, sometimes we like to model ones that are not, maybe they're basically too high. So we don't want a physiologically unreasonable dose of adoptive transfer. And by the way, this is not discretized very closely. So this is not super linear here. I'm sure we just needed more. I think we had at like 1, 2, 5, and 10, something like that. But ultimately we see that, as one would expect, as you increase the dose of adoptive transfer, we get more success. But it was a little bit interesting that too low of adoptive transfer actually, I mean, the steady states are close, but wasn't all that helpful. So this continues to be a work in progress, and I'm hoping by the end of the summer, my students have a few more interesting stories with the taper and with the differences in adoptive transfer. But main things are that we're trying to use mathematical modeling to kind of identify what's the ideal window for adoptive transfer or this combination of therapies. And it's important, especially because adoptive transfer is going to be inhibited by the immunosuppression. So we really do need to find this optimum. And then the results really suggest that doing that genetic modification is very useful. So if one could, and so this was the thing that excited Georgia the most, because he said that the clinical community would like to see such a difference, that so that's why we separated out the Treg populations. And if we genetically modify those Tregs that are being infused, to say those are not going to be impacted by the CNI mechanism, we saw that you could have a much better outcome, especially at moderate levels of immunosuppression. So we're trying to get more data because the contributions of these three parts of the cocktail, I should say, can actually be very different. So if one were to model it where the steroids were inhibiting, had the ability to inhibit it more than what we're currently modeling, that can also change things. So Georgia's already planning ways to get some of that data. And at the end of the day, we're trying to use modeling to really understand how a combined use of adoptive transfer and immunosuppression can lead to better outcomes for graft or transplant patients with improvement of quality of life. So with that, I wanted to leave time for questions. I would like to specifically acknowledge, especially Giorgio Raimondi, like I said, is at Hopkins and is an immunologist by training. Guang Lin is a statistician at Purdue in West Lafayette. And then I've had several students. Maddie was on this campus and worked with me last summer. McKenna worked with me both in a summer and academic year, and as she had been at Ball State. She had been at Ball State, and now she's a graduate student at IU Bloomington. Maya was at College of Worcester. And then I have some new RU students that are working this summer. So also support from NSF for the RU and my career award. And with that, open it up for questions.
Thank you very much. Tom, I think you said you had a question.
Yeah, a great presentation, Julia. Thank you. I've got a lot of questions for you, but I won't try to hijack the Q&A session here. So we know also that for example, so I think the CNIs or the different immunosuppression drugs, they lead to suppression of T helper 1 cells, right? But then because also T helper 1, T helper 2, they balance each other out. Then so if you reduce the amount of T helper 1 cells, then you get a larger population, or theoretically, you should be getting a larger population of T helper 2 cells. T helper 2 cells in turn produce IL-5, which is an activator to eosinophils, and then eosinophils produce IL-4 and IL-5 as well. So then you have a positive feedback loop of T helper 2 cells. And my son, who had a lung transplant, has eosinophilia, where he's got high levels of eosinophils, and it's have you seen or how do you account for that, or anything with your experimental models? Does that come up at all?
No, I mean, that's a good question. So right now, we're not technically delineating between TH1 and TH2, helper 1s and helper 2s. So that would be a good way to certainly increase the accuracy of this model. Now, we do have, even though I don't have it necessarily on the schematic, we do have these cytokine populations, but not always specific to type. So Giorgio has actually been wanting to add in an IL-2 population for other reasons, but you're mentioning IL-4 and IL-5. And so, yes, that is something that because we do have, and like I said, I have all of the equations handy. And so let's see. A lot of what's being inhibited in the T cell populations will have indirect effects, right, on the cytokine populations. But, what you're referencing and having that loop to see, okay, well, if the T helpers are going to end up increasing, then what's going to happen with IL-5? That's something we could absolutely build in and should. So it's a good question for sure.
Is that something you could calibrate in vitro? In other words, could you have an in vitro model of TH and then actually look at the specific cytokine responses, or is that not a practical experiment?
Maybe Tom knows more than I do about those experiments.
I don't. I'd have to ask my experimentalist.
I typically would ask Giorgio. But I mean, they do a lot of, I feel like, well, I'm not totally sure, so I'm not going to say one or the other.
So Could we come back maybe to at the beginning? You showed a list of the cytokines you included in the model.
So it was just pro-inflammatories.
Okay. So
And then
you don't break out the cytokines individually in the model at the
not
moment.
right now. So right now we only have a population of pro-inflammatory and anti-inflammatory,
Yeah.
which ultimately, yeah, I think that that would also be another good step, is to look at IL-2, and then Tom's giving me ideas about IL-4, IL-5, things like that. But no, they're not broken up right now.
You did some periodic dosimetry studies. Can we come back to that slide for a sec?
So this was number of doses given.
Okay, so the ATs are then, that was where I got maybe a bit confused. So the ATs are given periodically on a daily basis or on a fixed interval.
Right. It was on a fixed interval of days, and the day 0 means you start on day 0, and then
Right.
this tells you how many days you go for, basically. So day 0 for 5 days gets you here. So 14 doses starting at day 0 was kind of the best. Whereas 14 days, if you start at day 3, not as good. I mean, again, not as good. Well, none of them are surviving, but the steady state level is lower.
It's not a one-time therapy with the transfer of the ATs. You do give them periodically.
Right. And oh, that was one thing I forgot to mention. So I did have 2 students 2 summers ago who we looked at oral versus IV, and with oral, we did bolus dosing. And so it was kind of tagging on this pharmacokinetic model with our own model. And because really a patient is never being fully infused, or there will be depth. And so what we showed though was that the trend was very similar. So even though you had this oscillation in outcome, the trends were similar enough to like a constant infusion that it's just a little bit easier to model using constant infusion. So we went back to that, although it was nice to see. And clearly the absorption between IV and oral was very different. So actually oral was all suppressed. So like I said, this is best case scenario because everything's constant, it's getting in there right away. But when we actually implemented it, and she did a nice job by having to say, okay, how much was absorbed after you ingested this orally? Yeah, everything was reduced down. So then now this patient did not have as good of outcomes. So that is another important thing that can absolutely be taken into account. And we have modeled it. But now by looking at this combination therapy thing, we're kind of doing it best case scenario first. And then we could go back to saying, okay, well, what if we had bolus dosing or oral level instead of like an IV? Absolutely. So that's a good, thank you for bringing that up.
So does this give you any ideas about, I mean, you mentioned CNI by itself isn't enough. You need the combo, you need the combination, the cocktail to be able to do the early immune suppression.
Correct.
Does this give you any ideas about how rebalancing that might help? Or are there other cocktail immunosuppressants that might be less inhibiting for the ATs that would
Yes.
still be effective?
Yeah. Well, and yes. So we had been studying, so rapamycin is another drug that we had been studying, but I guess has a lot of side effects that are not preferred. Like patients don't like that one. So then we started focusing on CNI. But yes, so that's why Georgia is trying to plan these studies to get some data on these relative contributions, and also seeing like in the clinic, at what point do they reduce the steroid? Because ultimately the steroid, patients can't be on steroids long term, or like that's not good. So he has actually someone that does pharmacokinetic modeling who I think that we're going to start working with as well to try to get more information on those time scales. Because right now we're either assuming cocktail is always there, or we're assuming CNI is only there, but we're not actually reducing out. So like, how do they reduce out the steroid? How do they, or is MMF, do things go up or down? So that's the thing that also could become very interesting and is not in here yet.
I mean, it's a bit of a different question, but and maybe it would require thinking about additional immune components. But if you say, okay, we go with standard therapeutic regime for the first 2 months, and now are there strategies for inducing immune tolerance of the graft later on that would let you go off the immunotherapy?
Right.
What would it take to build a model that was focusing on those sort of the long term rather than these relatively earlier time approaches?
Well, and it was interesting because there's a recent paper that I think might be in publication now that was only looking a year later instead of earlier on. And I did have the question of, well, how do you necessarily get to the year? Because all of their dynamics started a year after the graft. And so it wasn't, because I was very curious about this study, but it felt like it wasn't a totally applicable to mine right away, because I would like to see the entire interim, right? So I want to see, how do we get from making sure that graft, because early on is very important, in fact.
Sure.
And so making sure that that graft stays high, and then, and I don't remember the full details of that paper, what their kind of combination was to prevent graft rejection. But it would be very interesting actually to see that study and say, okay, if they're starting a year later and they had a certain initial condition, and that was the other question I had for them. I was like, well, how do you know that this is the initial condition you're starting from if you're not modeling those 100 days,
Right.
or a year? I guess they were doing a year. So yes, to me, we would need more time points and measurements throughout, because jumping a year to me is not sufficient. Like, I think we need to know what's happening along the way so that we can actually see, okay, tapering this, increasing this,
Right.
relying on this, especially with, the adoptive transfer. So it's been used a lot in cancer. And there is some studies certainly in transplant. But no one would ever just give adoptive transfer because the graft would die, right? So, there's animal studies and things like this, but trying to get at kind of some of these combinations. That's why we're kind of using this theoretical approach, because it's really hard when you don't have a data set to work from, I should say, to know, well, if we say theoretically we can rely on this, first of all, can we get to the point where theoretically we can rely on this, and then try to design an experiment that would showcase this? So yeah, I think time scales, right? So matching of time scales. So this becomes a very different type of problem, because we're really kind of looking early on. And once you kind of reduce beyond some of those thresholds, then even though I take some of these grafts to steady state, my collaborator's like, well, I don't really care because the heart's not beating at the point that you're taking it to. He's like, I really just care if the heart is still beating. Yeah, understanding exactly time scales. Because right now I think patients, their regimen does change, like the steroid levels do change, but it's not fully accounted for in this model. Sorry, that's a long-winded answer to your question.
Right. No, I think mathematically what you're saying makes a lot of sense. I suspect from a clinical perspective, people think of preventing acute rejection early as a different problem from maintenance after you've prevented acute rejection and you've had a successful transplant.
Absolutely.
And
yeah.
so probably that would explain why the model is they say whatever happened, we're now in a situation where the transplant is accepted, but we'd like to taper the immunosuppressives, the long-term immunosuppressives later. I would say I agree with you that probably it's going to be hard to really understand that if you didn't understand what happened early.
Right.
But I think probably from a clinical perspective, they're thought of as maybe different problems.
Absolutely. Absolutely.
Knowing people who've had organ transplants and are on long-term immunosuppression, as you point out, everyone would like to not have the diabetes and the heart problems and the infection problems from those long-term immunosuppressives.
Right.
So I think it's a very compelling application. Well, I really appreciate you coming back and talking to us about this. It's especially impressive that you could do so much with. You must have some really good RU students to work with over the years.
I have actually, yeah. And McKenna, I was I'm glad she's at IU for grad school. I was hoping she'd come here, but I'm glad she's down there. She did a lot on this model, and yeah, no, we're hoping to get even, to get this funded in a way that we would have more continuous work on this project would be great. But Georgia remains very interested in this, and it's nice to have the support of someone who wants to rely on theoretical understanding to try to develop some lab experiments that he could do. So that's been very useful.
Well, I'd love to talk about that more. Maybe he'll come back and give us an update at some
Sure.
point.
Absolutely.
Okay, well, thank you, everyone. We'll see people tomorrow if you're on steering committee, and otherwise we'll see you in 2 weeks. Thank you again.
Thank
Bye.
you. I enjoyed it. Thanks.